Hey everyone, great to be back with Ahmad here, talking about their recent work in JACC, the effect of acoramidis on recurrent and cumulative cardiovascular outcomes in the ATTR-CM phase 3 trial, ATTRibute-CM, and some of the exploratory analyses. Ahmad, great to have you on.
Great to be here.
And maybe we could just get right into it. And for the clinician, sort of reading this paper, what do you think are the sort of big take-home messages from your guys' work?
Yeah, so there are some like direct takeaways and there are some indirect takeaways. So this paper looked at Acoramidis as a transthyretin directed therapy for patients with transthyretin amyloid cardiomyopathy. And the direct takeaway is that when you look at patients with this disease who were randomized to Acoramidis versus placebo, there was a change in the paradigm of thinking that you need a long time to start and see prevention of cardiovascular events. I think, even though this is post hoc, which we all acknowledge, ultimately, the recurrent events were adjudicated by an adjudication committee and were, blinded to what else is going on. And so when you look at that, you see earlier in the course of the trial that you're starting to accrue events and you're starting to see an effect of the drug to preventing these events. And so I think that's somewhat of a direct thing that you're taking away from that. The slight indirect, applicability of this is the fact that historically speaking, transthyretin amyloidosis was never regarded as a time-sensitive disease or diagnosis. Well, patients have chronic progressive heart failure. You have a long time to figure things out. But what this shows us is even over a shorter period of time, even over a few months, if you can shrink that time from suspicion to diagnosis to initiation of treatment, you actually can prevent cardiovascular events that are known to worsen patients, are known to be associated with mortality and things like that.
So the part that I'm harping on here is sort of from what you're saying, the left, on the risk curve, the more left we can intervene on, the better, right? And I think that's an interesting point because that's different to what we've kind of historically thought. And the point that I see here is if you look at the patients who kind of crossed over from placebo onto treatment and those who were on treatment the whole time, the sort of recurrent event rate is much, much higher in the folks who only got it for that last 12 months instead of the whole time. So I guess my question is, what do we do and how early in the disease process do you kind of think about intervening, right?
So great point. This is tied back to the pathophysiology of the disease combined with what our therapies do. From a pathophysiology perspective, this is a progressive condition that, over time, you're going to continue to have further deposition of the amyloid fibers in the heart and further worsening the, cardiomyocyte health as well as the myocardium in general. And so that's one aspect. And the second aspect is our therapies do not reverse the disease. Our therapies right now that are available stop it from progressing or slow the progression of the disease. As such, this is somewhat different. This is almost like thinking of prevention, correct? It's never too
Yeah.
early sometimes to prevent something from actually taking place, like when we talk about hyperlipidemia, for example. I'm not suggesting that we should transform this disease to something similar to that, but the reality is that once you have clinical evidence of the disease, there is absolutely no reason to wait for something bad to happen before you pull the trigger, just simply again because we can't reverse that. And so what you see from the last 3 clinical trials that have been conducted, even though they use different agents, if you just look at the placebo curves for mortality, for example, from these trials, you can see that just by identifying patients earlier, even though they're on placebo, their mortality is much less. And so that's our goal here, correct? Our goal is to get to the point where we are shrinking and fixing that problem.
And then, ATTR-CM is not something that's as common as, hyperlipidemia, right? So when I think about trying to intervene as early as possible, and for the clinician who's maybe concerned, what do you recommend is like the operational resources? Do we have the logistics in place at most of these centers, in your opinion, and kind of what needs to change in order to make sure that patients with this process sort of initially, are being given therapy as early as possible?
So that's a great point. I think right now what you're observing is that the bottleneck is in the referral processes. And I know a lot of this is geographic, but the problem is that this is a common disease. And in an aging population, I mean, we still call it rare, but the reality is that it is frequently encountered almost on weekly basis in heart failure and focused practices. But the reality is someone having some shortness of breath, some heart failure, they essentially are going to be waiting for months and months and months before they get even seen by a specialist. And once they're seen by a specialist, the workup is obvious for the patients who have clear disease and on echo and require confirmation. But for patients who don't, sometimes you have to do multiple steps and making sure they don't have light chain amyloidosis and confirming the transthyretin, sometimes in the biopsy for histological confirmation. That can take a long time. And on top of everything, once you establish the diagnosis, you also then need to try and work on securing the treatment, because these are special drugs. It's not like they can just go to any pharmacy and pick them up. So to your point, that's why I alluded to two parts of the problem. One is that will take time, and I think this is something we can intervene on tomorrow. We can try to fix that processes in our centers and our practice locations and practices. And the second part of it, which would require confirmation, is does transthyretin amyloidosis have multiple different mechanisms through which, if you address them, you could actually make patients feel differently or better? Or is it just the fact that you have to address the underlying disease pathophysiology and let everything falls into place? And I mentioned that, for example, because you see in this paper, there is an earlier, or what is deemed to be an earlier effect on heart failure. And the one thing that we observe with Acoramidis use is that you do have reduction in GFR. And so this is not an on-target mechanism of the drug. This is a renal mechanism of the drug. Initially was studied separately to make sure that everything is fine, which turned out to be. But slowly our thinking is morphing that if you look at most of the heart failure therapies that we have, actually that if they result in a reduction in GFR, because the mechanism there is distinct from just having reduction in renal function. And could that be partly the reason why we're seeing this earlier effect of the drug? This is something we're studying as we speak in the commercial settings of the use of these drugs. But see, this is the beauty of discovery, is that you use the drug for transthyretin amyloidosis, and suddenly you're seeing this like early effect, and then you start digging more, and then you see the renal effect, and then you start studying it more and more.
And you kind of pointed this out, but these patients have, even if we look at the group who were on treatment the whole time, right? The event rate is still 17% by month 42. And the point that you're bringing out is sort of, we have this TTR stabilizer, right, that in Acoramidis, and there are new therapies in the pipeline, and of course we have the traditional heart failure meds and an armamentarium around us. And I guess, how do you think next steps, right? How do we make the 17% 5% or 10%, or kind of continue to bring that down even for the folks who are on treatment?
And that's exactly the unmet need we continue to talk about, that we haven't solved the problem altogether. There is still an unmet need. Part of it stems from the delayed recognition and diagnosis. Even though we're doing great as a community in terms of identifying these patients earlier, when we looked at our data and some others' data as well in the last few years, we are still doing, like a lot of the patients are still symptomatic and have heart failure by the time they present. And as such, the more that you can push that earlier recognition more and more, I think the more that you can then get rid of these events from happening. We do have a small cohort of patients who were identified super early, before the onset of heart failure. They had no symptoms, and years later on therapy, they remain doing great. And so that's where we want to get from a small practice physician intervention perspective. Now, from a treatment perspective, the therapies currently available between silencers and stabilizers, they are not meant to regress the disease. Some patients do have regression of the disease, but that's an outlier. On average, you don't have regression of the disease, you have stabilization of the disease. And so we now have a whole host of newer therapies. Some of them are trying to push the knockdown degree much higher to see maybe that last few percentages of knockdown is where the magic is. I don't know for a fact that this is true or not. We'll find out in the next few years. But there is another group of drugs that are being trialed right now, which is what's called the depleter trials or the depleters. The depleters are monoclonal antibodies that it's a very distinct mechanism of action, goes after the amyloid fibrils themselves in the heart and incite or activate the person's own immune system to really identify this as a foreign, content of the myocardium and the muscle and tag it for essentially opsonization and removal. Now, we don't know if these are going to work or not. The phase 1, 2, and 3 trials are ongoing right now for a few of these agents.
And pivoting a little bit, I think something that I'm curious about is you guys looked at this sort of composite endpoint of recurrent events and focusing specifically on recurrent events, and kind of as you look to new trials in ATTR and new therapies that get made, what are different endpoints that you think are like, we should consider, kind of making, pre-specifying, making it the primary endpoint, or you think these are best left to sort of currently, sort of as exploratory analyses, just because I think the findings of this study were quite striking, as I was reading them.
Yeah, this is another amazing story in the history of evolution and development of clinical trials for a rare disease within cardiology. Is that initially, when with the understanding that there is a limited number of patients and you have to conduct smaller studies, people, us others started with, other approaches like the win ratio, where you're trying your best to catch any event and compare it in a hierarchical fashion. You start with mortality, then heart failure, then whatnot. And, that was ATTR and Acoramidis as well. They used the win ratio. And then, ultimately it was looked at like in this attribute trial, for example, if you actually look at the time to first event, for example, analysis, which is a very traditional way of looking at this, it actually had robust statistical significance to it. And if you look at recurrent event analysis, you end up actually having more power to detect differences because you have so many more events after your initial event in such a chronic disease. And so most of the recent trials have moved to this state, which is looking at recurrent event analysis and sometimes even modeling it, not just only looking at it, but also modeling it using some pre-specified factors that can contribute to the outcomes of these patients and using different models. So I don't think there is a right or wrong answer, but I think that in such a chronic illness that is driven by a primary disease process that we know of, recurrent event analysis probably fits in more with what we're trying to achieve. As long as we're clear about it, we're clear about what we're studying. What's happening is that you have then a whole host of secondary endpoints, including standalone mortality, standalone time to mortality, and whatnot. But I think the primary is morphing more and more into being recurrent event analysis.
And you guys had a supplemental figure too, where you guys looked at treatment and placebo, the number of events as a function of time, and the point being that a large number of people had in the treatment group had zero events, but there are this subset of patients which you're pointing out, right? These are the folks who have 2, 3, 4 plus events, and that's where the burden both to the patient on quality of life exists, and you guys pointed out in the paper, and then also where it exists in terms of the cost to the healthcare system, right? Meaning if we can offer intervention early, right, that's where the benefit is for these folks who are going to have recurrence of disease multiple times, and this is just me looking. This is a similar sort of reasoning set that you see a lot in oncology and sort of like the sort of landscape of preventing the burden of disease from accumulating. That's just a point that I thought was very interesting.
Yeah, I fully agree. And in this scenario, we actually have the tools that allow us to tackle this early. And while we want therapies and we want more and better and improving patients, we can today start by acting on identifying these patients earlier, shrinking that time, so that you could achieve in a way similar outcome to having some of these newer therapies. You can achieve it just by really scaling and shifting back your intervention earlier in the disease course. And that's what we emphasize. Like when we go on these educational talks, we emphasize that it's amazing that in 2026 we have 3 drugs approved for the treatment of transthyretin cardiomyopathy. But in my opinion, what's more important at this stage, aside from having the treatment available, is to develop processes that can capture these patients early in the disease process.
Yeah, there's that implementation science of it, right? Like we have something, we need to make sure that people can get it and get it in a timely fashion. And I think that's a problem that we have to solve, in the near future. Ahmad, what's an unanswered question, unanswered thing that you feel like is, probably the most compelling thing that, in the ATTR-CM space for you personally? I mean, that's sort of maybe my last question to you.
Yeah, it's really hard to pick one thing. There are so many things happening in this space. If you think about, there are newer, medications coming out in terms of, knockdown agents and silencers. There's permanent gene editing. There's the whole new class of depleters, coming out as well. There is the question of combination therapy. Does that matter? Is that better than a monotherapy approach, which we don't know anything about? I alluded to the fact that with Acoramidis, there's a question of what is going on with the renal effect and how beneficial is that? And then finally, as we are treating these patients more and they're living longer and they have systolic dysfunction or combined systolic and diastolic dysfunction, it is really time. I mean, this is not in 5 years from now. This is the time to start and thinking about how can we investigate traditional heart failure therapies, neurohormonal modulation in this disease, not wait another decade before we start saying, we have patients with heart failure, we control the factory problem with the amyloid, but we haven't addressed the other underlying issue. So many other things are happening, but I think the things that are in our control are to try and figure out how can we study and run trials of other commonly used heart failure therapies in these patients who are already being treated with transthyretin directed therapies.
The concomitant medications and regimens that we can build around that. Thank you for your time today. I really appreciate it, and it was great chatting.
Pleasure joining you. Thank you.